And here we go. Welcome, everybody, to another episode of The Big Idea, where we talk about how it is that a little bone at the base of the head can have a profound impact on your health, well-being, and can also change your life. And this one here is not exactly a favor, but something that I'm actually doing for a friend who has been having a lot of different issues. And she's given me the permission here to share a few things that are showing up on a few of her scans. She's concerned about craniocervical instability. In brief, she's been having anxiety, headaches, neck pain, dizziness for a really, really long time. She had told me that she had had a really nasty injury when she was a wee little kid. She's always known that she's had different kinds of jaw issues. She was even told as a little kid that in order to fix this, we're going to have to, quote, break your jaw and reset everything. She also has a few metabolic things, so what seems to be a little bit of autoimmune-like symptoms. She has been diagnosed with what's known as mast cell activation. That is where the histamine and the inflammatory processes that are going on in the body are going a little bit crazy. So she's sensitive to mold, humid conditions, different kinds of things like that. And she does suspect that she is somewhere along the Ehlers-Danlos or the Ehlers-Danlos hypermobility spectrum. But she doesn't have where the joints pop all the way in or out. As is oftentimes the case here, this has become a little bit more of a buzz term, a common diagnosis these days for people where they're trying to understand what's going on. And I've had a look at a few things, and when we've chatted with her personally, it's like, well, I don't think this is a true blue Ehlers-Danlos, but that doesn't mean that even if you're not at that full level of pathology, that you can still have excessive amounts of stretchiness. And if there are things going on with the person's upper neck, with their jaw, that can mimic and produce the exact same symptoms of a craniocervical instability. I oftentimes talk about this, that the C1 and the C2 vertebra, these are the universal compensation joints in the body. So whether you have a problem up at the very top, whether you have a problem in the jaw with the cranial bones, or elsewhere down in the spine, guess what? It's going to be the upper part of the neck that is going to compensate for that. And yes, there is a time and a place where one may need injections, things like prolotherapy, where a person's going to need stability kinds of activities. But what I want to illustrate here is that there can actually be problems going on with the neck and with the jaw alignment. And the consequence of that is it's producing excessive stretchiness. And if you can solve that, it may not solve the connective tissue underlying disorders. It may not solve the mold exposure issues or the hyperinflammatory processes going on in the body. But what it can do is it can increase the amount of wiggle room, the amount of give, to where people can actually experience a bit of relief. So what I wanted to show you here were her scans, so that I can illustrate just a few of the things that I'm seeing here that may be important, and hopefully gives a little bit of insight for other people who may be experiencing some of these things as well. Things to be on the lookout for. Let's jump into it. All right, so what do we have for you guys here? We have what's called a CBCT, or a cone beam CT. This is an upright image, and when we're looking for things such as craniocervical instability, there's a few different options that we have available. So one of them is what's known as a DMX, so digital motion x-ray. This is where a series of x-rays are taken with the neck in full flexion extension, turn to one side, turn to the other, and then sideways like that. And you can look at the individual joints then to see if things are moving way too much, way more than they should be. What you can also do is you can have what's called a CBCT, or a digital articular x-ray. In brief, we're all different on the outside and the inside. And what this allows us to do is this allows us to come in from pretty much every single angle that you would want to see, so that you can determine, okay, are the individual joints properly lined up or not? So this is done with a person's head in a neutral position. And with that, you're then able to see, or what you should expect to see, is you expect to see that all of the normal joints, whether they're in the jaw, whether in the upper part of the neck, that they are properly articulating. They're lining up like this. And where we see displacements based on a person's individual anatomy, if we can see something like this going on, something like this going on, we say, that's not supposed to be there. And we can have an appreciation then for the relationships going on. And when it comes to like the true blue instability, what we're talking about is we're talking about displacements where the vertebral surfaces, so the articular surfaces, are off basically like this, upward of around 50% of the total joint surface. And what we oftentimes find, though, is that people, it's like, no, they're not to that full degree. There's something that's off by even a millimeter or two. But if you compound that single 1 to 2 millimeters over a long period of time, that's like unpaid compounding interest. And imagine that it was only 1 to 2%. How nice would that be? But when you multiply that over decades, you better believe that that's going to have a very, very significant effect. And because the 1 to 2 millimeters is so relatively small, if you're looking at these things from the point of overt pathology, you go to the emergency department, they take an MRI scan, they take a standard CT scan, they're going to say, nope, we see no signs of pathology. I agree with that. But just because there's no signs of pathology does not mean that things are necessarily healthy. Well, and this can be something that, of course, can drive a person toward the point of insanity, trying to find a resolution, because what they're experiencing is 100% real. But it means we got to look at it in a much more detailed and personalized perspective. So what we have here is going to be her scan. And this one here, I'm using a little bit of a low res, resolution here. So I can actually get way more resolution, but it works better on my computer for this video purposes that I want to show you right here. So what are we're looking at? We're looking at the side of the head right through here, facial features, teeth, jaw, and then we're looking at the overall health of the bones, the joints. And this is an important one, the overall curve of the neck. The normal curve of the neck in this particular case should actually be like a reversed C shape, or in this case, a C shape like this, based on how she's facing this way. But I think that what you can see here is that the curve of her neck is going backward like this. And that is very commonly a telltale sign that what we are dealing with is we are dealing with tension on the muscles, on the ligaments, but also on the spinal cord itself, because brain's going to be somewhere sitting in here, and then spinal cord is going to come down like this. This is the normal position where things are going to be most flexible. But as the curve straightens, what that does is that increases the amount of tension. And over time, that's the effect of me poking you in the arm like this. 1 to 2 times, okay, yep, you're not going to be very happy with me. You might ask me, please stop. You'll probably lean away from that a little bit. And then if I still keep doing it, you're going to want to punch me. Point is that if a person's neck is locked in this kind of an abnormal position, then what's going to happen is that's going to be producing a lot of neuromuscular symptoms. And because the spinal cord is essentially anchored right in this area here, we're most likely going to have symptoms associated with that part of the body. There's going to be headaches, this is going to be dizziness, this is going to be migraines, and if it's going on long enough, it can actually contribute toward chronic pain, chronic fatigue, fibromyalgia, and any number of conditions that are associated with either a craniocervical instability or what's called a craniocervical syndrome. Now, in this particular view, what I want to showcase are going to be a couple of things first that actually fall a little bit outside of my scope in terms of what I do clinically. But these are still things that I'm very aware of because, I'm not going to be able to solve 100% of all things for all people, but I need to be able to identify where things are going on for a person that can be contributing. One of the things that I want to illustrate for you first is her very, very high jawline like this. If you're looking for like the corner of the jaw right there, ideally we would see that that would be sitting somewhere around here, down at this level. This is what's known as a hypoplastic jaw. This is something that happens oftentimes. Yes, this can be an inherited feature, but this is also something that can happen when we're a wee little kid and we're learning to walk, learning to run, things like that. We trip, we fall, we jar the joints in the jaw, and as a result, the bone doesn't fully develop. And it's opposed of it being like that normal square-ish shape with the bottom part down around here, it can come up very, very high like that. And that is a bit of a risk factor then, because it increases the amount of tension like this and causes the jaw essentially to pull back like that, which strains the different muscles that are going to be anchored in and through and along the front part of the neck. As that happens, that can decrease the airway. But what it can also do is it can act as a source of mechanical pressure that is either going to cause a narrowing of the different structures along the front of the neck. These are going to include the internal jugular vein. This can include the internal carotid artery. That's not near as common, but the internal jugular vein definitely is common. It can also involve irritation of the vagus nerve, which is going to be communicating all of those vital life signals between your brain down to the entire rest of your body, your heart, your lungs, your digestive, your reproductive system, all of that. And it can also irritate what's known as the superior sympathetic ganglion. It's a cluster of nerve cells located basically right here in front of the C2 and C3 vertebral bodies, goes up to the head, and it regulates blood flow. It regulates lymphatic activity to all parts of the brain. And this, if this is irritated, this will very commonly mimic symptoms of vagus nerve dysfunction. A person's going to be feeling constant sense of anxiety. They're going to have heightened inflammatory responses going on in the brain. And if you affect the brain, you affect everything in the body below. And this can be something where a person is feeling that, the body's just going, crazy at any given moment. And it can feel a bit better sometimes when you lie down, but sometimes doing that then can also increase a sense of dizziness or vertigo that a person experiences. So it's a bit of a really nasty series of combinations there. It's essentially where the body's playing a trick on the brain and the brain is then playing a trick on the mind. My point being is that when we see something like this, we know that the normal margin of error is going to be decreased. And this is also important. As people do experience some of these kinds of conditions, there is very seldom ever just one magic little thing that's causing all of it. It's usually a combination. And my point that I just wanted to illustrate here is that the structure of the jaw is a huge one for these kinds of people, and oftentimes requires management with what's known as a neuromuscular dentist, and very likely also with somebody what's known as a myofunctional therapist who prescribes and does different kinds of activities with the tongue, with the reflexes for swallowing, sometimes with a speech pathologist if this is caught either as a little kid or even as an adult for that matter, ultimately to restore the normal function of that airway, which is going to influence, how much oxygen you're getting into your body. So a little bit important. I wanted to highlight that first and foremost. Now, what I'm also going to do on our little scan that we've got right here is we're going to have a look at it from behind, kind of like this. And what I'm going to do is I'm going to draw a couple little dots like this, kind of along the left-sided features here, because a couple of the structures that we're going to be looking at on a few additional views here, it's not going to be abundantly clear which way is left, which way is right. I mean, it's pretty obvious even if you've never studied anatomy. Okay, yeah, there's a person's face, here's the neck. So the little dots that I've put on the different bones, let's put one more right there, because that's going to be an important one in just a second. Basically, the dots are going to illustrate all along the left side, okay? So let's go ahead and switch the view just a little bit here, and we're going to look at this in a little bit more depth and detail so I can show you what I'm seeing. Alrighty, so what we're looking at now are different slices. And these are going to be relatively thin slices where we can look on the inside of the individual joints from every single angle that we want. And let me just quickly grab there we go, there we go, there we go. Something like that. Okay, you can completely ignore what all of these little numbers are right through here, but I simply wanted to do that so that you can see where those little dots were. Remember, I pointed all the little dots on left-sided features. So on this particular scan, we're looking at the left side of her neck, kind of from a front to back or back to front perspective. So this is her left side. And if I was to then shift this a little bit more, come on, let's find it, let's find it. There we go, there we go. So same thing down on the lower picture right there, right there. When we're looking at this one down here, this is going to be the left side as well. So left side is on your viewing right, and then right side is on your viewing left. Now, I will zoom in just a little bit on this picture here first, and we're going to make it a little bit bigger. And what we can see, this is like a mid-slice cut as we're looking down along the back of the vertebra in her neck here. And I'll point out this one here at the C3. We can see the relative shape of the bone. We can see the disc spaces between there. That one seems to be relatively normal. But if I was to come down just a little bit more at this level here of the C5 and the C6, you can see that this one is more squished, is the short of it. Degenerative arthritis. That area has been under constant stress and strain for a long period of time. Think of degenerative arthritis like rust. You've left a bike to rust out in the rain for 20 years. That's what I'm seeing right here. And I'll make a note that this person here, she's not even 40 years old. So we look at that, and that lets us know that even if she was to say she only started to experience these symptoms a week or two ago, the process has been going on for a lot longer period of time. And that's important. As much as we would love to say, snap of the fingers, hallelujah, boom, the problem is gone, problem is solved, most of the time, these are going to take some time. And I oftentimes say, especially when there's more than one thing going on, this is like you're parallel parked in really tight, not just on two, but on three sides. You're not going to be able to get out in one nice, simple move. This is going to involve a little bit of A, a little bit of B, and a back and forth process, slowly increasing that flexibility, that margin of error. And hopefully then, even if there's not, one magic cure for these kinds of things, we're still able to find functional improvements so that things are able to be more adaptable, less bad, and a person is start to be able to experience better quality of life overall. Now, what I'm going to do is I'm going to come up, and I won't lie, I'm just going to be eyeballing this here. There's a lot more advanced measurements that we need to be able to do, but I want to point out a couple of things here first and foremost. We're going to come up to the level at the base of her skull, right through here. So this is from that sideways perspective. This would be the base of the skull here. Here's the back part of the skull, and here is the opening, where the base of the brainstem is normally going to be sitting right about the level of the C1 and the C2 vertebra. So it would be located right in this area right here. And I want to draw to your attention this white little spike right here. This is what is known as the Basion. It's the front part of the opening at the base of the skull, known as the foramen magnum. And there is an interesting phenomenon that goes on in the body. It's called the Wolff-Davis law. In brief, if you have a muscle or a ligament that attaches onto a bone, and if that muscle or ligament so happens to have a lot of tension on it for a long period of time, what the bone will do is it will start to remodel itself. It'll lay down more calcium as a way of trying to maintain and preserve as much structural integrity as is possible. And I will illustrate that the triangle that you see right here basically would end where I've got that magnifying glass. But then we see that spike coming down like this. Now, granted, this is a bit of a thin slice, so maybe that's not the most accurate. So let me, on purpose, make it a little bit thicker. Even when I do that, I see that this would be the quote-unquote normal end of the bone like that. And this part here is where the body has laid down more calcium. And I'm going to make a little measurement, and I'm going to do it from two spots. I'm going to do it from where the bone had originally ended, so approximately here. Again, this is a little bit of an eyeball. 1.5 centimeters, so basically half an inch, a little more than half an inch. And if I was to come down then and do one more line, maybe, from the bottom of that little spicule there to the top there, now we're measured at, whoops, didn't mean to do that, at 7.3 millimeters. This is what's known as the Basion-Dental Interval. This is a measurement that we can use to determine if a ligament is under constant or chronic stress and tension. When we see, and the numbers are a little bit different whether we're looking at an X-ray or a CBCT slice, and we're still trying to figure out what's going to be appropriate when you're looking at things in a weight-bearing posture. But in an adult, this should be less, absolutely yes, for true blue pathology, less than 1.2 centimeters. And what we can see, if we're looking at where the bone originally was, we're talking about a 1.5. So we're definitely over the limit. And if we were looking at it then in the standard on a standard CT slice is 8.5 millimeters. She is at, if you look for how the body has remodeled for it, 7.3. So again, even though we may not be at the point of overt pathology, there's some stretching that's going on. Something is causing the C2 vertebra and the base of the skull to separate like that. There is increased stretchiness that's going on in this particular area. Now, does that mean that it is yet unstable? Necessarily not. But I do see that there is a little bit of a factor here that needs to be taken into account. So would it be for this person a good idea to be having a lot of manual therapy, to be doing a lot of head or neck stretches? I'd look at that and say, no, that is probably not going to be a good idea, because the last thing that you would want to do, even though it would feel so good to just lift the head up like this and take the pressure off of the neck, off of the shoulders, that might increase that amount of tension there. Now, same breath, does that mean that this area from an upper cervical chiropractic perspective can still be addressed and corrected? The short answer is yes, but it means that you have to take that into account and you have to be very deliberate in what you are doing so that nothing that you do is going to make that any worse. Now, the next thing that I'm going to do is I'm going to do a look, again, this is an eyeball method, so there's a lot more detail that goes into that. But I'm going to look at the structural integrity of the joints between the base of her skull and between that C1 vertebra. And then, as I said, everybody is different on the outside and also on the inside. And so what I need to do then is I need to line things up based on her individual anatomy. And I'm going to look at the joints to see if they are sitting properly, the way that they should be, or if there's some evidence of an offset, either what's called an overlap or an underlap. And that, I repeat, unless you see a 50% loss in the normal joint integrity, that's not necessarily an unstable condition here. Okay, so what are we going to do? We're going to line this up approximately with the plane of her C1 right there. And now what I'm going to do is I'm going to shift the slices like this. So I'm lining up, again, eyeball approximate with that joint margin right through here. And I'll make that just a wee bit thinner because that's a little bit too thick, at least for the resolution that we got there. So I'm going to make it narrower than we normally would analyze on purpose, but that way I can point out what we're looking at. And let me decrease that angle just a little bit there. All right, so what we've got here is you've got the edge of the base of the skull sitting right here. Now this is on the right side, and what we see is we see that that C1 basically is lining up right with the edge. In other words, quick glance, nothing looks too weird right there, which is good. Now, if I was to come over then onto the other side, like this, and this one, it's showing up a little bit easier, and again, I would usually use a slightly thicker slice, but for, well, yeah, that'll work even for illustration purposes. Now we're looking at the left side. So the left side of the base of the skull comes like this, and is forming a nice sharp edge with the top of that C1 right there. Again, I'm looking at that and I'm saying, okay, things actually don't look too bad. In other words, the C1 is lined up. I'm not seeing evidence of significant instability or anything like that. But what I'm going to do now is I'm going to draw your attention here just a little bit lower, and I know that some of these crosshairs might get in the way, and I want to illustrate this area right here. This is the space between the C1 and between the C2. And you may notice that the base of that C1 is not, I repeat, is not lining up with the edge of the C2. And it appears, at least from this slice, to be off by a total of 2.4 millimeters. Now, this is a little bit of a projectional distortion, and we can't assess what's going on in this particular area of the spine just on that one little measurement there. But what this suggests is that there is some kind of a rotation that's going on in this particular area. And a lot of times people, they talk about or have concern of what's known as atlantoaxial instability. There's a big difference between instability. That's basically where the joint is so far rotated where a person's head is caught like this and they can't bring it back. It's a condition that's known as torticollis or wry neck. But that's going to be when you have a huge amount of displacement. Again, you can measure it upward of around 3, 4, 5 millimeters. 2.4, that's not quite meeting that threshold, but it is, again, suggesting that this person, her head, is caught somewhere within its normal range of motion with a rotational element going on. And I'll show you now what that looks like. Okay, we've zoomed back out for just a quick second here, and I'm going to draw your attention to this image right here. Two things I want to highlight. Number one, first, is if I'm looking at the overall arch of her teeth. Again, this is kind of outside of my scope of practice in terms of what I do, but I can still see that this is what's going on. Her upper palate is way too narrow. When the upper palate is too narrow, that oftentimes is what causes the jaw, the lower jaw that is, to have to find some place to go home. And what it's going to do is it's going to go back like that. And that can be one of those factors, again, that puts compression on the TMJ, and also what is going to decrease or narrow that airway as well. In fact, this wasn't the order that I was planning on doing it, but let's go ahead, let's have a little look here. If I was going to shift the slice here, we're going to look at this picture right here. And what I'm going to do is I'm going to zoom in on her TMJ. So that joint right there. Do you see how there's not really, like any space between this part of the bone here and then where that jaw sits? There's a little bit of cartilage that should be on the inside of that. And when we see that there is next to no space, we know that what's happening is there is a TMJ compression. And that cartilage has nerve receptors that go to the parts of the brain that are responsible for not just pain, but also muscle tone, tension, and also to the parts of the brain responsible for balance, equilibrium. And if there's a problem there, that can spill over and cause a person to experience some really, really nasty senses of anxiety. Now I look at that and I can also see it's like, whoa, the shape of that has really changed over a period of time. It should be more of a rounded cup like that. And as you can see, there's a little bits of spikiness. It's been flattened out a little bit. So this jaw, and this is the side on, this is the right side here, this has been under stress and strain for a really, really long period of time. This is not going to be something I'm going to be able to personally adjust and make it all go away. Yes, there are certain, procedures that we can do for that, but every time a person brings their teeth back together, guess what? It's going to default back into that kind of a position. So this is definitely where you're going to need a team of people to help out. There's not going to be just the one, quick, nice resolution, as much as we wish that we could have that. And this here is her jaw on the other side. So we're now looking at the left. You don't see the same degree of bony remodeling that's gone on the other side, but same thing is, yeah, there's a joint space right through there. It's this little black line that you see around the edge here. But this should be sitting more with that flat portion right there. And this can be very frustrating for people because they can have, they go to their, general dentist who, of course, they know way more about teeth health, gum health, all that sort of stuff than I do, but they're going to assess a person's jaw and they'll say, okay, open your mouth. No, it seems to be opening in a relatively straight line. This is what's known as a posterior compression. It is shoved way too far back on both sides. And as a result, it's essentially compressed and it's locked into that position. What this person very likely needs is she needs that upper palate to be made broader and to be working with those myofunctional therapists in order to expand that upper palate. And as that happens, that allows the lower jaw to come forward, which will decompress this area and hopefully will help, because the alignment, the structure, the motion of the jaw is going to affect the way that the C1 and the C2 vertebrae move. In the same way, the C1 and the C2 affect what's happening up at the jaw. But we got a little bit off track there, but nevertheless, that was, something that I see here that's kind of important. So what I'm going to do is I'm going to zoom it back out like this for just a second. And we're going to line that up again approximately with the base of the skull. Now, this is where it'd be nice if I could delete all of those little dots there now that we know what the left and the right side is. There we go. That is better. So base of the skull, and here is the opening right through here. And I think that what you can see is, if you're looking at the crosshairs, that basically is lining up where we're looking right through the middle of the opening that we would see right through here. Now, when I start to scroll down a little bit here, this would be the level of the C1. It is essentially a ring sitting around a peg right there. The ring is the C1 vertebra. The peg is the top of the C2. That's going to be our pivot point that allows us to rotate our head. And what you can see is, okay, that's actually sitting not too terribly bad. That's pretty good right there. And you don't see significant shifts to the side, which would suggest, at least in the neutral position, that this person, has major ligament damage. But if you were to come down then just that little bit, I want you to look right here and watch what happens. Bang. That C2 vertebra versus the C1 is kicking really hard over toward this again. Remember, this is the left side. And this would match what we were seeing on that frontal projection. Do you remember where we saw that the edge of the C1 and the C2 wasn't quite sitting properly? That's what happens when that C2 is going to pivot toward the left side. The left side of C1 will appear like it is beneath or under relative to the two. So we're looking at that. Something in her basically alignment is causing that C2 to kick hard toward that left side. That should not be like that. And if, again, she's just holding her head in a neutral position, that would be the equivalent as if you turned your head toward the left side the way that I'm doing right now, but it's essentially gotten stuck there. Remember what I said about that constant chronic low-grade tension just adding up 1 to 2% compounding interest for a long period of time? This is very likely going to be contributing in some way toward the symptoms that she is experiencing. So the question is where is this possibly coming from? And I am going to thin the slice up again. This isn't exactly how we do it, but this will work for illustration purposes. And what I'm going to do is I'm going to come down just a little bit lower, and I'm going to zoom in right through here. You might be able to see in our lower left these little black lines right through here, like that. And then this one's a little bit more obscured, but there it is right there. These are the joints between the C2 and between the C3 vertebra. This is the way that they're supposed to look. There's nothing weird here at the moment. So what I'm going to do is I'm going to take this and I'm going to rotate that so we're looking at it in the side profile picture. This is the column of, well, this is the right side. This is the column of joints along the right side of her neck. The C2, the C3, the C3, the C4, C4, and then the C5. And I'm going to zoom in just a wee little bit like this. Now what I want to point out to you right here, and let me see if I can use arrows. Yep, let me see which way they go. Okay, those points are not really going to show up well at all, but we'll do the best that we can. You might be able to see that there is this spike coming off the back of the vertebra like that. Remember, the body lays down little bits of calcium when the edges of a joint have been under constant stress and strain. And that little spike extends a bit beyond the base of the C2 onto the C3 here. And you may, my crosshair kind of gets in the way, so let me just move that out of the way for just a moment. And it made a little shift there, but we'll still be able to see what I wanted to point out here, is that you can see there's a nice straight edge that comes up like this, and then there's kind of like this little notch, this extra little bit of bone that's going on right in and through this area here. So I'm going to try to draw another arrow. Well, that one's nice because it's bright yellow. That essentially, those are the margins for where the joints should normally be coming together. But what I want to illustrate for you is that if you're looking at the oppositional surface, its margins are actually located about here, down through about here. In other words, what we're seeing here is we're seeing that on the right side, that joint has come back down like this. What that does is that causes that C2 spinous to swing over toward the left side. And one of the ways that the body will try to compensate for that is it will actually cause it to shift toward the left. So we are seeing some evidence. This is a stable condition. I will say that. This is not an unstable misalignment at all. But if it has gotten locked in this position, it needs to be released. Otherwise, that compensatory C1 and C2 is going to be the area that's bearing the brunt of that area. Now, if I was to do then the exact same thing, flip it over now, we're looking at the left side here, and I'm going to try to get a somewhat decent slice. There we go. That'll do for us. And we're looking, let me see if I can glide that down just a little bit. There we go. So it's now a little bit more right in the center right through here. We're seeing actually the exact opposite phenomenon going on. So here's the C2 sitting right here. Here's the C3. And as you can see, the joints are, relatively close. However, if I do that exact same thing with my arrows here and here, that is the C2. Here is the C3. And I repeat, this is not, whoops, didn't mean to do that. This is not an unstable condition, but this is and represents a condition where the joint is essentially trapped in the wrong position, as if this person's head was, let me get this straight here. This person's head is locked this way and then turned like that. So try that for just a second. And this is over exaggerating, but tilt your head deliberately toward the right side and then turn back toward the left like this. Grossly over exaggerated. But this is where her head is locked. And it has been there, again, based on the amount of wear and tear that we're seeing there, that bike that's been left out in the rain for at least 20 years. Do you think then that that can have an accumulative effect of continual agitation that's going to be producing and leading to a lot of really nasty neuromuscular kinds of symptoms? I would argue, yes, it can. Now, would I be willing to say that this is 100% of what's going on? Absolutely not, because as we had already said, we know that this person's been diagnosed with mast cell activation. We know that she has some stretchiness of her ligaments anyway. We know that she has a TMJ kind of issue as well. My point is that she has a combination of different things that are all going on. But this is one of those missing elements. And I'd love to say that this was going to solve like 80% of everything she has going on. I can't say that. This may be 20% of what's going on, but oftentimes where people experience these kinds of issues, that's important. It's to understand that there very seldom is ever just one thing. And instead, we have to look at things where, okay, we're going to need a team of specialists working together to figure out, how do we unscramble this combination line? How do we get you out of that parallel parked in this much here? You're going to need a little of this, you're going to need a little of that, you're going to need a little of this, then you need to come back to the other one to work to ultimately improve a person's adaptability and ultimately restore their overall health, life function, all of that. And as we wrap up, I just want to come back to this particular picture right here because I can show you exactly what we just saw right through here. I'm going to zoom in just a little bit. So we are looking at the back of her head right through here. Here's that midline where that base of the skull on the C1 sits. And I think that you can see here is the back of that C1. Here is that C2, the edge of it right there. They are rotated like that. If we come over, change our angle just a little bit like this. Let me zoom in just a little bit there, and then we'll slide it over so that you can see what I'm looking at. This is that right joint margin right through here. And what it appears to have done is it appears to have shifted back just a little bit. And I do emphasize that just a little bit this way. The far bigger issue that I see is if I turn it around the other way from back to front, looky what we got right there. That's where that joint is sliding up on that left side, which matches exactly what we're seeing right here. That vertebra is kicked toward the left side right through here. And let me point out that there's a time and a place for injections, either to give a little bit of relief or to strengthen it back up, something along the lines of a prolotherapy. However, if you were to strengthen the joint in the wrong position right there, guess what? You superglued it and it's going to stay stuck there as that constant sense of, or that constant source of irritation. So very important, again, when we're looking or considering the concepts of craniocervical instability, you need to make sure that the joints of the neck are moving, not too much, but also not too little, because oftentimes the joint that is not moving well enough is going to affect the other ones. And if you end up treating the effect but not necessarily getting the underlying cause, that problem can persist. Therefore, it requires a team. I hit that again. These kinds of issues, they require a team of people working together, but also having a clear understanding of what's going on so that you can get the best possible chance of relief and improving your overall quality of life. So thanks for hanging out here for that little video. I hope you did enjoy it. If you did, I've got a couple of favors. Number one, please do like and subscribe to the channel here. That way it helps other people find this particular information if they need it. And if you've got a friend or family member you think could benefit from watching this video, please do share that with them. If you want to get in touch with me to find out is there anything that we can do to help you out, you can go to my personal website, which is drjeffreyhanna.com, where you've got all kinds of other blog articles, videos just like this one that talk a little bit more, again, the big idea, how it is that a problem at the base of your neck can affect your overall quality health life and can also change the way that your life goes forward. And if you're in the Eastern Washington or the Northwest Pacific, you get in contact with us at our team. I'm a member of the team at Clear Chiropractic in Spokane. You can visit us at clearchirospokane.com or give us a ring at 509-315-8166. Thanks again for watching. Till next time, this is Dr. Jeffrey Hanna at Clear Chiropractic Spokane. Get well, live well, stay well. Till next time, take care. Bye-bye.